Welcome to Variations 4. This is the cardiovascular unit. We're going to be covering numbers 6 and 7 in this video. In essence, talking quickly about preload and afterload and managing chest pain, especially from a pharmacological point of view. Okay, so number 6, we're actually going to start with the concepts of preload and afterload because that makes more sense to then talk about everything else. So what is preload? What is afterload in your own words? So if we look at a picture here, here's a picture of preload. Preload could be defined as everything the heart has to push against within its own chambers. What it has to work hard to evacuate from its own chambers. Preload can be problematic in two ways. If preload is too small, then you're not ejecting enough blood out of the heart. But if the heart, on the other hand, if the chambers are overfilled, then you're making them have to work too hard to get rid of that fluid within them. So preload has to be the right amount, not too much and not too little. And if we want to look at afterload, afterload is everything the heart has to push against that happens after the chambers. So for example, you can see the right ventricle here having to push against pulmonary pressures. The pressures in here are the afterload that it has to push against for the right chamber. For the left chamber, you've obviously got the aorta going out to the rest of the body. The pressures in here are the afterload that that ventricle has to push against. So here's a question to see if you understand. If blood pressure increased in the body in general, does that increase or decrease afterload for the heart? Increases workload for the heart, whether it's from fluid overload or vasoconstriction or atherosclerosis. If there's some kind of narrowing of the blood vessels or increased pressure in the blood vessels that the heart has to push against, we would say that the afterload has increased. All right, so if we go back to our questions here, we're looking at map 10 and explaining how nitro and morphine decreases workload of the heart. So let's get something clear before we look at that. You want to decrease workload of the heart because this helps to A, prevent cardiac events like angina or MI, but it also may be needed to help relieve cardiac events like angina and MI. So either way you cut it, decreasing workload on the heart is good, although you don't want to decrease workload so much that you end up with hypotension either. So let's look at these two meds and see how they help to decrease workload on the heart. We go to map 10 for that. Nitroglycerin, first of all. So nitroglycerin may be in spray or IV form. We see it in spray quite often. On the step-down units, you see it in IV if you're on a cardiac unit or an ICU. First of all, you need to check that BP before you start anything. If your BP is too low, and the unwritten rule is we start asking questions about administration when we hit 90 systolic or lower. We should be really hesitant to give anything if systolic is below 90. But that's an unwritten rule. You can always double check with a physician. Anyways, how does it decrease workload on the heart? So as you know, you give nitroglycerin and you get vasodilation of the coronary arteries. You already know that because you've been giving nitroglycerin for angina patients. as of course, you know, it also causes systemic vasodilation. That's why we have to check BP before we give it. The net effect is a drop in BP. And as we just established earlier, a drop in BP causes a drop in afterload. It also decreases preload because if you drop blood pressure, it means there's less blood returning to the heart. And so ideally, you're decreasing the overall workload of your heart and increasing your cardiac output. Morphine, other part of that question, works the same way. Morphine also causes vasodilation and a drop in BP, and that decreases afterload. Morphine also decreases pain, which will also decrease vasoconstriction, decreasing the fight or flight response, decreasing afterload. Respiration rate drops, which also helps to decrease the stress response. And morphine can have effect on heart rate, lowering heart rate, which in and of itself could also cause a decreased afterload, thereby decreasing cardiac workload. Whenever we see a decrease in afterload, we can potentially see a decrease in preload because, again, afterload is generally speaking a drop in blood pressure, and a drop in blood pressure yields lower returns to the heart. Okay, so now we look at question, we have to talk about aspirin. What are the beneficial effects of aspirin? It's a fairly quick concept. It's going to have to do with platelet aggregation. Decreasing platelet aggregation helps to prevent any kind of coagulation event, thereby keeping arteries nice and open. That's probably the main thing, is the platelet aggregation. All right, just looking at question 7 of these cardiac questions here, talking about MONA. MONA stands for morphine, oxygen, nitroglycerin, aspirin. I want to say right off the top, MONA has come under scrutiny and some controversy over the years. It's definitely a debatable topic. However, it is an intervention strategy that your textbook does support. And since we're following Lewis to follow our national exams, we're gonna go with MONA. But we're going to talk about some of the limitations of MONA and some of the things that we need to consider when we are considering these 4 interventions of morphine, oxygen, nitroglycerin, and aspirin. First of all, off the top on those lines, this is not, MONA is not in any way directive of the order of interventions. When a patient complains of chest pain, we don't typically give morphine as our first, unless we know it's, pleuritic pain from pneumonia. That's a different story, which we'll talk about. So it's not an order of events. It's just an acronym to remember what kind of interventions we would consider. It doesn't happen in that order of MONA. Okay, so that all being said as our kind of caveats and disclaimers, let's just talk about this. First of all, let's go through these cases here, these mini cases we've got in the program here. And let's just take a step back and think about chest pain in general. So if I just give you a nondescript patient and I told you it was a 55-year-old male who was complaining of chest pain, what do you want to know? I mean, if that's all I give you, there's probably a heck of a lot more information you're going to ask me, and you should ask me, that you want to know. For example, you're going to want to know things like, well, right off the bat, if someone off the street or a relative told me that, I'd probably want to set the vital signs right away. Like, what are the vital signs? What is the blood pressure? What is their rest rate? Their O2 sats? As much as I can get, give me all those vital signs. You're going to want that for sure. But even none of that's going to mean a whole lot to you unless you know some kind of history. You want to know, okay, if we're talking about a patient in the hospital, what was he admitted with? If my patient was admitted with pneumonia, is a fairly young patient with no cardiac history, and they're admitted with pneumonia, then I'm probably thinking more along the lines of this is some kind of pleuritic pain, this is some kind of lung pain. And I'll do some explorations in that vein to look at, what kind of pain is this? Am I confirming it? It's pneumonia, this type of thing. I want to make something very clear before we go any further. At no point in time can a nurse stand by the side of the bed and rule out cardiac involvement. In fact, if you want a clear example of this, look at the emergency department. If someone comes into the emergency department saying, I think I have pneumonia, my chest hurts, I can almost guarantee you that as well as doing the chest x-ray, you're going to be getting an ECG, maybe even troponins done. Because no one's in a position to take a verbal from a patient and rule out chest pain. I want to make that really clear. No one, not even a physician, I mean, they'll make their own calls, but no one can say for 100% that there's no cardiac involvement. So although in these next few little cases we're going to talk about, we talk about teasing out the difference between pleuritic pain, which is lung involved pain, and cardiac pain. Although we do that, I want to be clear that we're not trying to divert cardiac workups or cardiac diagnostic testing. We are never going to stand by a bedside and go, no, there's no cardiac involvement here. We're not going to do that. We're always going to want to consult a doctor to investigate further, whether it's ECGs, blood work like troponins, et cetera, et cetera. That being said, we also want to be thinking critically, and that's what these cases are about. So now that I've given all the disclaimers, let's talk about this. So let's give you some information on this 55-year-old male that up to this point we really don't know much about, except that he's complained of a very vague kind of chest pain. So what I can tell you is this. Here's some more details on him. Here's his vital signs. And here is some history from the MAR and the chart. No history of cardiac issues, no nitro or PRN orders. Why did I say no nitro and PRN orders? Admitted with pneumonia. I said no nitro orders because one thing I always like to remind the students is that looking at your PRN meds can be literally a lifesaver in some cases. And I'll give you two quick examples. I have found many times I looked at charts, I've looked at, I'm in a rush in the morning, I'm looking at the chart quickly, I'm looking at history quickly, and I see no mention of angina. And it could just be that someone forgot to put it in. It could be as simple as that, but it's not there. The only thing that's tipped me off to the fact that this patient has some kind of angina issues is that when I looked at the PRN meds, I saw nitroglycerin. So that's why it's so important to look at your PRN meds. Another example is for PRN hydralazine, for example, for high blood pressure. I see students come back to me, they tell me, oh, my patient's got a blood pressure of 185 over whatever, 98 or something. Okay, so you reported it to the nurse. That's great. I'm glad that you reported it to the primary nurse, but were you also aware that there's a PRN med we should be giving for blood pressure above 180? Well, no, I'm not. Well, that's because you didn't check the PRN orders close enough. Okay, so he's admitted with pneumonia. And we ask him to describe the pain, and this is what he says. So it sounds like it's pleuritic. Now, again, I want to stress that doesn't mean that I wouldn't talk to the doc and say, hey, when's the last time we did an ECG or troponins? I would look at the chart and I could probably find that out myself. And like I said, in the emerge department, they're going to do an ECG here anyways. So, you know, I really want to know, is the pain the same as it was or better than when you were in emergency? And if they did an ECG there and nothing's changed since then, it's getting a bit better, then so be it. I'm going to, still report this and chart it, but I'm not going to be too worried. If the patient tells me, well, the pain's getting worse and it's changing in a way, and it's a little more crushing now or whatever, I might be thinking, well, is there cardiac involvement now? Now is the heart under increased stress? And then we may want to do some diagnostics. Anyways, he's in for pneumonia, so we're really talking about antibiotic. We're talking about analgesics to help with his pleuritic pain so he can breathe more deeply and avoid atelectasis, further issues with atelectasis and pneumonia. We may want a chest x-ray to visualize his lungs. Well, as I said, you may want to still get your ECG and troponin to rule out any new cardiac involvement. Okay, next case. What do you check before going in the room? Always check your MARS. This is a new patient here, post-op day 4. I have a history of AFib and CAD. Here's our scheduled meds. We've got the ASA there already. and you got some PRN orders. Again, you recognize this nitro order. You've seen it before. Very common order. Now your patient is complaining of chest pain. What do you do? Okay, well, I've already given away some of it here. You assess the findings, and you find it's looking like some pretty typical angina going on here. So what do you do next? Trying to scroll up here to get you in the groove here. So what do you do next? All right. Obviously, you need to take a set of vital signs. You probably thought, well, I want to give some nitro. Of course you did. It makes sense. But you can't do that until you take a set of vitals. You take a set of vitals, and here's what you get. There's your vitals. What do you do with that? Where do you go from there? Sure, apply your O2. Now, this is the deal. Any oxygenation below 95% and chest pain involvement, you're good to, you should be giving your O2 to get bump your patient up to 95%. Once they get to 95% though, you know, or if they're already at 95%, you don't really need to give the oxygen. In fact, this is one of the caveats I was talking about earlier on. Over oxygenation is contraindicated. So 95% is good. Let's just get up to there. Give your nitro spray. Your vitals say you're okay. Now what do you do? Okay, obviously reassess the patient. You may also want to know if there's additional ASA that needs to be given. And if you find yourself that you've given the nitro 3 times and still not effective, you might need to get some IV morphine on board. Of course, you're going to want to check blood pressure before you give the IV morphine, or before you have someone who has scope of practice who's allowed to give IV morphine, give the IV morphine, like the RN, for example. What else do we have here? Yeah, probably some ECGs and troponins for diagnostics. This is a repeat here of what I said earlier. Check your BP before you give any additional. So what if you gave those 3 nitros, the patient's still complaining of chest pain, and BP's too low? Maybe there's another dose of nitro that can be given, or maybe you've given all your nitro, you want to give morphine. But the real question I'm trying to ask you, BP's too low now. You've lowered BP, it's below 90 systolic, and the patient's still complaining of chest pain. What do you do? There it is. You might need to consider calling a code. What ultimately is going to may have to happen is if it's allowable in terms of kidney and renal and heart function. I mean, you may need to give a little bit of fluids before giving the pain med, but you might need to get a code team involved here. I believe that's it for our case.